Hi, my name is Kayla Ashley, and this is my Pulling It Together for October 28th, 2020. My client's initials was JH. He is a 34-year-old male, full code status. He's not on any isolations, and he has no known allergies. He does have a history of smoking, ETOH, IV heroin use, methamphetamines, and hepatitis C that was never treated. He also has bursitis, which is inflammation in his bursa, and he came in on October 23rd with complaints of left-sided weakness. So on the morning of October 23rd at 8 a.m., he woke up and he was rushing to get ready for work. And all of a sudden, he lost vision in his whole left field. His whole left face went numb and his whole left leg went numb. And he turned to his girlfriend and he said, "Something's not right. Let's go to the hospital." And she took him to the hospital, and there he was admitted. So when he arrived, he did get a echocardiogram, and it showed that he had an ejection fraction of 60%, and there was vegetation seen attached to the mitral valve leaflet, the aortic valve, and he had a severely dilated left atrium and a severe mitral regurgitation, as well as moderate aortic regurgitation. He also received a CT, and it showed hepatomegaly. So that'll play into some lab values later. And then he had proctocolitis. So today they were trying to figure out where the proctocolitis came from. So on assessment, my patient was alert and oriented times 4. He was very conversational. He had clear lung sounds. He was on room air with an oxygen saturation of 98%. He had a temperature of 97.5. His heart sounds had S1 and S2 present, and there was like a slight murmur. It was very hard to hear, but there was a slight murmur. And that's related to his diagnosis of endocarditis. And yes, we'll get there. His diagnosis of endocarditis. He had a heart rate of 69, blood pressure of 112/68, and he had a venous access right forearm 22 gauge. And in this gauge, he was receiving ampicillin. So let's go back. He did have endocarditis found with his um, with his echocardiogram, and when you have endocarditis, you're at risk for a stroke, and that is what happened to this patient. So during endocarditis, there is vegetation or bacteria that builds up on the mitral valves, and at any point in time, it can break off and go into circulation. And because of mitral valve regurgitation, it can get thrown up to your brain, and you can have a stroke. And that's what happened with this patient. So that's why he had all the left-sided weakness. He probably had it on the right side of his head because it usually crosses over. The effects usually cross over. And he was on IV heroin, and he had a positive toxicology for amphetamines. And IV drug use is a big cause of endocarditis, as well as dental surgeries. And if you look at his mouth, he has rotting teeth all over his mouth and teeth with abscess, and we'll get into what they're planning to do for that a little bit later in the video. But those are two reasons, two causes of his endocarditis. So back to cardiovascular assessment. He had 2 plus pedal pulses and 2 plus radial pulses. His capillary refill was less than 3 seconds. And for DVT, deep venous thrombosis prophylaxis, he was getting low dose heparin, and he was also ambulating. He did refuse to wear SCDs. He wore them at night, but he didn't really want to wear them during the day because he is able to walk, and they didn't have a bed alarm on or anything like that. He just got up and walked pretty frequently, walked himself to the bathroom, walked in the room just to prevent DVT formation. Um, when listening to his vowel sounds, they were hyperactive, and this was related to his NPO status. So this patient was NPO, nothing by mouth, because later in the day he was getting a tooth extraction to remove any teeth with abscess on them. So that's why he was NPO, and they were hyperactive, and he kept complaining that he wanted to eat. But they didn't want to cancel his procedure, so he had to remain nothing by mouth. But we did give him ice chips every now and again. His last bowel movement was yesterday, October 27th. And then as far as integumentary, his skin was intact, it was dry, and there was bruising on his lower abdomen related to heparin injections. And he did have a birthmark on the left side of his head. Next, as far as genitourinary, he voided by himself spontaneously. He got up and went to the bathroom. He's not incontinent. He didn't have any complaints of trouble voiding. For pain, he did say he had right shoulder pain, and it was rated as a 6. We gave him Tramadol PO, and we also gave him, diclofenac sodium gel, and we rubbed that on his right shoulder, and that was used to relieve pain as well. He rated it as a 6, and then after I came back, he said it was a little bit less. So it did do what it was supposed to do. He also had a lidocaine patch ordered, but he did refuse it because he said that they don't work. So yes. Musculoskeletal, he had great strength. He was able to move around. Like I said, he moved to the bathroom. He walked to the bathroom. He walked in the room, walked up and down the halls by himself. He had very good strength in both of his arms bilaterally, in his arms and in his feet. He was able to like push and pull and grasp really strong. So any signs of the CVA, the stroke, have been resolved. So he has all of his vision back. He has his mobility back, his feeling back. He didn't report any tingling. So the symptoms of the stroke are resolved. And like I said earlier, he did have dental caries, and that is related to the methamphetamine use, and they are getting extracted to prevent any more complications of the endocarditis. His treatment for the endocarditis right now includes antibiotics. He did have positive blood cultures, and he has been having positive blood cultures, so he isn't like getting better, so to say. He is on ampicillin and ceftriaxone for that. So they're just trying to see if they can get like a negative blood culture to see when they can finish the antibiotics and do his surgery. He was also on atorvastatin because of the CVA, the emboli that broke off and went into his brain. So that was just a medication that they put people on whenever they have like an emboli or a thrombi. And so the plan for this patient, like I said, he has the dental extraction coming up, and he was screened for syphilis because in his CT they saw the proctocolitis, and they wanted to rule out it being related to syphilis, chlamydia, or gonorrhea. So they did that swab, and they're waiting on those results. And he also will eventually have a valve replacement for the repair of the mitral valve, but first they're trying to get the vegetation, the bacteria under control by giving him those antibiotics. So it's not scheduled yet. They will address his history of hepatitis C later on in his treatment after they get the valves under control. And for right now, he will be transferred to either another Sentara hospital, or a emergency room on contract, because he is getting a PICC line for antibiotics, and because of his history with IV drug use, he can't go home with the PICC line, so he'll be staying there, and they will be providing him resources for substance abuse and things like that. Another thing I wanted to address was his laboratory results. He did have a decreased red blood cell of 3.54, as well as a decreased hemoglobin and hematocrit 10.7 and 33.2, and those can both be related to the stroke. Strokes can cause anemia in patients, so that is why that is present. Another cause, another theory that I have for the cause of the low hemoglobin, hematocrit, and red blood cells is he has a history of hepatitis C that has been untreated. And I know that hepatitis C could progress into liver cirrhosis, leading to hepatorenal problems. But the only problem with this theory is that he didn't have any abnormal BUN or creatinine. But if that were to be a part of it, then the decreased function of the kidneys would lead to decreased secretion of erythropoietin, leading to overall decrease of hemoglobin, hematocrit, and red blood cells. Lastly, upon reviewing my patient's EKG strip, he did have sinus rhythm. His PR interval was 0.06, his QRS complex was 0.08, and his ST segment was 0.3. So my nursing diagnosis for this patient is imbalanced nutrition, less than body requirements, related to insufficient dietary intake because of the NPO status, as evidenced by hyperactive bowel sounds, food intake less than recommended daily allowance, and the patient constantly asking for food. So a short-term goal for him is once the NPO status is lifted, whenever he finishes his procedure, to consume adequate nutrition and nourishment. And then a long-term goal is to progressively gain weight toward his desired goal. So some interventions are we should weigh the client daily, schedule rest periods before meals. He is getting like a lot of procedures, so rest before meals would be good so he has energy to eat. Provide good oral care, especially because he's getting the teeth extractions. So you want to make sure the oral care is good so that he'll be in the mood to eat. Offer high protein supplements to promote healing, and that's just based on the individual's needs. And upon evaluation, the client will have met his goals and interventions will be completed as stated.